I'd like to welcome everyone to another installment of our Insights World Tour. We're coming now virtually from Spain and with two excellent speakers, which I'll introduce very shortly. Just reminding you again that by definition, the Insights World Tour is a very by design small group session. We aim to make this with a small group so we can have a meaningful discussion after the presentation. So in this particular case, you will see that, well, what we'd like you to do is during the presentation, if you could, we'd like you to stay muted and off video. And we'd also like very much to remind you that this is being recorded. So once it's recorded, we'll edit it and will be sent out to our 75,000 members that are our members around the world across 160 some odd countries on ortho evidence. But we should really encourage you to speak and interact after our presentations are completed. We'll ask you to come on to video, show your face, and keep your audio on, and we'll have a great discussion thereafter. So without further ado, we are going to be talking about definitions. We're going to be talking about the definition of a joint infection, and we're also going to be talking about the definition of success and outcomes following the treatment of prosthetic joint infection. So two friends, colleagues, researchers, and scholars, and academics. As you know, I suspect this group knows who we're speaking about, but both doctors Guerra and Minguell are both working in Barcelona at the University Hospital Vall d'Hebron, Barcelona, Spain. Friends and colleagues, please help me welcome two exceptional colleagues and friends. I believe the first presentation will be Dr. Guerra. Dr. Guerra, welcome and thanks so much.
Okay, thank you so much, Mo, and thank you everybody for listening today, and especially Mo, congratulations for your evidence-based orthopedic book. Surely it will be of tremendous success. Yeah, tremendous success. Surely the orthopedic community will enjoy it, and we will have a lot of knowledge inside your book. Congratulations.
Thank you so much. And thank you for contributing.
My friend. Yeah. So I will start with my talk. I don't know if you can see it. Is it okay?
Yeah, it's great. Thanks.
Okay. We're going to talk about periprosthetic joint infection definitions. Orthopedic community need, it is extremely necessary to have a clear and reliable definition of PJI. Unfortunately, until now, diagnosis of periprosthetic joint infection is based on criteria, as is rheumatoid arthritis, as is lupus and ankylosing spondylitis, and many other diseases. There is no any test, serological or synovial test that will 100% diagnose the periprosthetic joint infection. During the last 10 years, there has been 6 definitions reported in the orthopedic literature. This has made a concern and some confusion to the orthopedic surgeons, especially because there has been some conflicting reports about some serological and synovial markers. But even though there has been a lot of work from different community of orthopedic surgeons that has made the last decade one of the most relevant in the treatment of diagnosis of periprosthetic joint infections. We're going to focus especially on the definition of the International Consensus Meeting from 2018 and compared with a recent report published from the European and Bone and Joint Infection Society definition that was published this year. The aim of the talk is to talk about the evolution of the definition of the ICM. We're going to talk about the strength and limitations and compare it with the MG's definition. A group of surgeons from the US published the AOS guidelines on 2020, and it was well received by the orthopedic community because until then there was no any clear way to diagnose the PJI. The same group of surgeons they made the definition of the MCs on 2011. On 2013, a global group made the definition of the international consensus method. This definition has been widely accepted. It has been used in research and it improved the quality of the literature until now. Sorry, I don't know what is happening now.
Ernesto,
okay.
No, okay, perfect.
Okay, it's okay. 5 years later, the new definition, the last definition from the international was developed. It was based on the of the last orthopedic. It reported a scoring system. It was validated with an external cohort, and it compares to the previous definitions. This is the definition. There are two major criteria. The diagnosis. This is the phase of the definition to diagnosis. There were 3 serological markers and 4 synovial markers. Every one of these tests were scored depending on the weight of the statistical analysis of the literature. More than 6 points were considered infected, between 2 and 5 probably infected, and less than 1 or 1 not infected. And if we cannot make the diagnosis with this preoperative phase, we'll go on to the intraoperative diagnostic test that, adding to the preoperative score, 6 or more points infected, 4 or 5 conclusives, and less than 3 not infected. We're going to talk about the strength limitation of this definition. Even though it was a based on a retrospective study, there was a big and it has been dated in many countries outside the United States. The validation algorithm established that if any serological marker is positive, we should move on the patient to the aspiration of the knee or of the hip, or if any of the serological tests, if all the serological tests are negative, we should also consider bone aspiration if we have a high rate or suspicion of that the prosthesis is infected. After these 3 steps, the sensitivity is very high and the specificity also. Another strength of the definition is that every test, the preoperative one and the intraoperative ones, were scored with a model based on the weight that established the statistical analysis of the orthopedic literature. It is not an arbitrary score for every step. So after 80% of the patients of the cases were diagnosed in the preoperative phase. Another strength is that it is an stepwise approach which minimize the false positive or false negative cases, and it avoids underdiagnosis and overdiagnosis, and it helps to reach early the diagnosis of periprosthetic joint infection. The step 1, as we have said before, it is based on the serological test. 45 variables were analyzed to make the diagnosis in this definition. The serological test considered that CRP, D-dimer, and ESR have the highest diagnostic values, and it was a score, as you can see in the slide. And if any test is possible, the patient should move on to aspiration. But if there is any of these other variables are present, like revision arthroplasty, like previous surgeries, or a recent surgery, or some clinical signs and symptoms, if one should do an aspiration also if we have a high suspicion of infection. The step 2 corresponds to the synovial test, white blood cell count, alpha defensin, and leukocyte esterase were given the higher scores based on the statistical analysis. And after the step 1 and step 2, only 3% of false negative cases were reported with this definition. As we have said, step 3 is intraoperative finding, and in order of importance is histological analysis, the presence or not of purulence, and one positive culture. Another strength is probably that a high proportion of patients the diagnosis is made preoperatively, which give emphasis to the importance of doing an aspiration of the hip or of the knee. This definition was compared with the previous definitions also, and it is considered that false negatives only were reported in 2% of the cases with the 2018 International Consensus Meeting definition, and it was much more sensible and specific than the other definitions. This definition was presented in the International Consensus Meeting of 2018, and the delegates were agreed with the definition only in 68%. This definition has many limitations, especially because it is based on retrospective analysis. Bone scan and sonication has not been considered. There's no differentiation between hip and knees, and it is difficult to obtain an accurate diagnosis in inflammatory arthritis or patient that has been treated previously with antibiotics, or in cases of adverse local tissue reactions. We are going to make some comparisons with the EPJI's definitions. The European Joint Infection Society and some other groups criticize the International Consensus Meeting definition. Most of these criticisms are not scientifically justified, but definition of EPJI's was considered to be useful to capture low virulence infection of the implants. The EPJI's definition, this is the sequence of the development of the EPJI's definition. The three authors identify a lot of important articles, and the executive committee made the draft of the definition. But the articles that were used for this definition and the methodology was not documented, at least to our knowledge. It is not known the consensus reached by the assembly or delegates. There are some discrepancies between the two definitions. The EPJI's definition do not differentiate between acute and chronic. There is wording variance with utilizing the likely infections. But what is important is that they consider that a single test can make confirmation of the diagnosis of infection. but it is well known that there is no any serological or synovial test that can confirm any infection of any implant, as it is established by the FG's definition, considering the alpha defensing as a truly positive or accurate test for diagnosis. And the score made by the ICM definition is not arbitrary, as I said before. 2 months ago, this abstract was presented in the meeting of the Musculoskeletal Infection Society, and trying to establish the accuracy of the FG's definition. They utilize this number of infected cases and accepted cases, and this is the sensitivity of the ICM definition and the FG's definition, which is very different. And they conclude that the FG's definition has very low accuracy, and that the FG's overdiagnose and overtreat near 20 or 30% of the patient, which represent a lot of morbidity and sometimes mortality to the patient due to the aggressive of the procedure to cure the patients. As a summary of this talk, the international consensus meter definition is evidence-based, it is validated, it is a guide, not all tests are needed. Preparative diagnosis is possible in high percent of the patients, but clinical judgment should still prevail. That's all, my friends, and thank you for your attention.
It's a pleasure, Mo, and all the audience to be here. It's a long time ago that I can see in a real time, and it's a really pleasure to meeting with you. First of all, welcome to the Insights World Tour to all the audience. I will speak about the definition of success of treatment. This is a very important issue. As you know, the incidence of deep infection after primary total knee arthroplasty is rising and projected to reach around 7% in 10 years. This in our hospital in the first quarter of 2018, this happens, and this is not a theory, it can be real. And we know that it's challenging for clinicians, dramatic for patients, and is a very important expensive for the healthcare system. No? And to prevent and to treat correctly PJI, we need a good medical education, a good research, and also a international validated definition. From the definition of PJI, like said Dr. Guerra before me, and also definition of success of treatment. We need all these considerations. As Dr. Guerra says before, PJI definition has helped to standardize research and also the treatment of these patients, management in general, by providing a consistent population among studies. But also, we need also a standardized definition of success and outcomes following treatment to compare these different strategies. The goal of treating PJI is multidimensional. In general, we only focus in eradication of the infection, but also we need to be aware of improving in function. That our patients need to be satisfied, and also we need to avoid medical and surgical complications. In this study, and this is a review published by Diaz Ledezma in 2013, is a review about all the different definitions of success and also definition of failure, and they know that's very heterogeneous, no, and only focus in infection eradication. And there is no a multidimensional concept of success of treatment. In the same paper, the aim of these authors was to give a multidimensional definition of success of treatment with different dimensions. There was agreement in different aspects, but there was not agreement in the functional level, There's no agreement in this important issue, and also there is no agreement in what means a short-term result. They considered 2 years for early results, but there's no agreement. It's very interesting, but there's no agreement in this dimension, because they ask about the functional level. They're very worried about the functional level of these patients. And I think it's very important. It's not only the eradication infection. And they want to propose, but there is no consensus in this definition. They propose in this consensus to ask to the patient if the function at the end of the treatment of the PJI is equal or better than before the index arthroplasty. They also want to ask to the patient, is the current function is better or equal before the diagnosis of PJI. They are also interested in what is this improvement is minimal clinically important. Is really this improving in this functional scale important clinically. They also are worried about the patient satisfaction and also the absence of psychiatric comorbidity. As I said before, there's no consensus in the functional bit, but I think it's a very aspect to discuss later. More recently, a work group creates this outcome reporting tool based in a gradient scale, not a dichotomous variable. It is divided in 4 tiers. Tier 1 is infection control with no continued antibiotic therapy. Tier 2 is infection control with the patient on suppressive antibiotic therapy. Tier 3 in general is defined as failure, but is defined and need to be classified in 6 categories. Category A is aseptic revision more than 1 year from initiation of PJI treatment. B is aseptic revision also at more than 1 year from the initiation of PJI treatment. C and D are aseptic or septic revision, but less than 1 year. Also, the amputation, resection, arthroplasty, or arthrodesis is defined as a failure, and also spatial rotation. Tier 4 is death, different, and they differentiate if this death is in the first year or in the more than 1 year later. And with these tiers, can classify the 3 categories of outcomes. Tier 1 and Tier 2 is considered a success of treatment. Also, Tier 2 this is infection control. The patient is in suppressive antibiotic therapy, but also this is considered infection control. Tier 3 in general is considered a failure of treatment, but we need to consider that the group A and B, that the failure or the revision aseptic or septic is more than 1 year. This is considered a failure, but a failure to the secondary cause different to PJI. The other cause, aseptic or septic revision in the first year, is considered a failure relative to PJI, and also amputation, resection, arthroplasty, arthrodesis is a failure, and also a retained spacer. The death is considered a failure of PJI if the death occurs in the first year after the initiation of PJI treatment. But to correctly manage this outcome reporting tool, we need to know different definitions and consideration that we need to take into account to do a real outcome reported tool. First of all is the starting point. This is very important. In the first definition by Diaz-Ledesma in 2013, the evaluation began after the reimplantation surgery during the second stage. But now the work group prefers that the starting point began at the time of the initial operation of a PJI. And this makes sense because the starting point influences the size of the population, because we know that the reimplantation in general, depending on different studies, around 80%. And we have an attrition bias of patients. And also the reported treatment success. We have a reporting bias because with the Diaz-Ledesma criteria, we start here, in this case in September 21, but in the recent definition, we start in the first surgery related to PJI. In general is a debridement antibiotic and implant retaining. And this is very important to have this consideration of the starting point because it influences very the results. Also, the infection control, the work group defined infection control as a patient not meeting the MSEIS criteria for PJI and not having or needing any additional surgery. But we need to exclude the reimplantation logically, if a complication of a spacer like luxation or a planned soft tissue surgery. Of antibiotic therapy has been defined as cessation of antibiotics during the first year, during the year after the initial surgery, during the year. But patients are still allowed to be on short periods of treatment, for example, a short treatment of prophylaxis of dental manipulation, for example. Reoperation in general means failure, but we need to clarify this because I said before, the A and B, when the revision is later than the first year, we consider that the failure is secondary not to a PJI directly. But revision in the first year, amputation, resection arthroplasty, or arthrodesis, and also a retained spacer is considered a failure. The follow-up is different. The work group considered that the minimum follow-up is 1 year. The group of Ledesma considered 2 years, but they are agreed that mid-term and long-term results are 5 years and 10 years, respectively. Respectively to death that occurs at the first year is considered a failure of the treatment. And this work group says that it's very important the appropriate use of this outcome reporting tool. And to classify the patients, we need to know that each patient can be assigned only to a single tier. And this is very important that in every publication we publish this or report this table, because this improves transparency. And we thought that it is necessary to report in every publication of PJI treatment. For example, this is a recent publication of a group of our hospital, and they publish this table correctly. You can see in this this is a revision of 2-stage exchange arthroplasty in chronic hip and knee periprosthetic infection. You can see there are 116 patients with infection control in tier 1. Tier 2 is because there was only 1 patient with antibiotic suppression with infection control. They means success. Tier 1 and tier 2 means success. Tier 3, that means reoperation. We can specify is this reoperation is septic or aseptic, and also is this due in the first year or in the later than the first year of the initiation of treatment of PJI. There were 2 cases of resection arthroplasty were classified. 18, that means 11% of spacer rotation. This also means failure. 4 deaths, 3 in the first year. This is also considered a failure due to PJI infection, and 1 is not considered because it's later than 1 year. But this is very important to report this to improve transparency. And if you note, if you define success with the criteria of Ledesma, the success rate of these cases are 80%. But if you use the criteria of the work group, recently, the success rate was 71%. And the same article, they conclude that the exclusion of patients who do not undergo reimplantation result in a 9% overestimation of the success rate in this area. It is very important that all the physicians that treat this kind of patients speak the same languages. In the second international consensus meeting, in the section outcomes, there was a question. The question is, what is the definition of success of surgical treatment of a patient with a periprosthetic joint infection? And the recommendation is the treatment of PJIs typically does not have a dichotomous outcome, as I said before. And we need to use this classification in 4 tiers, and the agreement was 82%, and that means a strong consensus into the delegates. But maybe this definition is not enough. We need to improve. The same work group has identified areas for relevant consideration. The first one is to develop a validated tool to measure prompts. As I said before, in the consensus from Ledesma, there was no consensus about the functional assessment of the patients, and also future modification of the outcome reporting tool in light of the new definitions. And to finish my talk and to take home messages, it's important that the success of treatment of PJI is a multidimensional concept. It's not enough to say the infection is eradication. We need to ask about the functional of the patient. The outcome reporting tool has 4 tiers as a gradient of outcomes, and we need to use. For correctly use this outcome reporting tool, we must know the consideration and definition for an appropriate use. This is basic for research and transparency in all of the publications. And the International Consensus Meeting reached a strong consensus about the recommendation of using these outcome reporting tools. And this is all. Thank you for your attention.